All right, let's talk about our site selection and how to avoid common errors. So the first thing you need to know about errors in central lines is that need to know that there are mechanical complications from placing central lines. So you should always know the alternatives and when to use the alternatives, and central lines are the last resort for vascular access. The other thing you need to remember is the safest central line is the one you didn't place. So if you can get by with a PICC line or a midline or a long dwell peripheral IV, those are much better alternatives than a central line. Now, when we're thinking about site selection, there's a lot of things to think about. What we're going to talk about is that our site selection and how we place our central line is directly related to how easy it is for the nurse to maintain that surgical site, that sterile site where we've inserted our central line. So the first thing we're always going to recommend is a subclavian location. That, for many reasons, may not be our choice location, though. So if you're going to go to an internal jugular, we're going to recommend the low internal jugular position, and we'll show you that in just a second. And if you're going to have to resort to our femoral location, which is our least favorite, we want to use a mid-thigh location. We will show that also. Just remember that these techniques that we're about to teach you are related to how well you can maintain the dressing in the surgical site. Now, you have to know where you're going before you even start. So always pre-scan, select your site, consent your patient, then gather your supplies, because your supplies are going to be related to the site you pick. So if you're picking something on the right, you may use a shorter catheter. So a right subclavian generally goes in 15 centimeters, so you'll use a 16 centimeter catheter. The right IJ is variable. It depends on the height of the patient. So a tall person will use a longer catheter, whereas a short woman maybe would use a shorter catheter. So you will either use a short 16 or the longer 20 on the right IJ. Anything on the left side is always a 20 centimeter catheter, and if you're doing a femoral location, it's always a 20 and sometimes a 24 centimeter catheter. So when you're thinking about site selection, again, the subclavian is the lowest for central line associated bloodstream infections because it's the easiest to take care of. It's away from the drool line. It lays flat on the chest, the dressing, and so it's easy for the nurse to maintain. However, the subclavian is the most difficult line to place for new central line inserters, people that don't have as much experience. So if you're new to placing central lines, we recommend the IJ location because it has the lowest mechanical complications. Again, femorals are worst of everything. So we're going to go IJ if we haven't placed a lot of central lines, and subclavian if we can do subclavian lines. So how do we make an IJ safe like a subclavian when we're talking about sites? Well, here is an internal jugular catheter. Notice that the dressing is laying flat, but it's up around the ear, so we cannot maintain this dressing because the contours of the neck and the face. Also notice that the dressing is going over the beard. This means that there will be an air gap between the dressing and the skin. Also note that if the patient is laying a little bit to the side, their drool will run right down across the dressing, decreasing its adherence, but also contaminating the site. So when we're talking about IJs, what we would prefer is placing a low IJ close to the clavicle, not a supraclavicular approach to the subclavian. We're still talking about the internal jugular vein, but as low as possible so that we can place our dressing off to the side and not in the ear or the beard line. And importantly, the best practice is to turn the catheter away, turn it down onto the chest or out on the neck so that we can get a flat dressing and we're out of the beard line and we're away from the drool line. So when you've studied in books, it talks about Celadose triangle. This is a landmark technique, and the Celadose triangle is actually results in a central line insertion site that's far up the neck. We want to be as low as possible. We want to use ultrasound. This is the advantage of ultrasound. So we're going to slide down so that we have enough room to walk our needle down before we hit the clavicle, but our insertion site is far down on the neck. This is a cadaver picture showing this. So we are way down the neck. We are below Celadose triangle. We're not at the apex, but we're not up near the jawline, the red where there's going to be drool. We're not in the yellow line where there's beard hair and things for us to make the dressing not stick. And so we recommend being in the green. Green is good. If you end up having to put in a central line in the neck in somebody that has facial hair, remember to clip that beard before you place the central line. But better yet is to avoid this location at all possible, or to use a low IJ approach so that your dressing doesn't even come into the beard line, because beards will grow back. And as they grow back, they're hard for the nurse to maintain. Same kind of concept with the femoral line. You're taught in many textbooks when it comes to the approach for this is that you're going to be inserting 2 to 3 centimeters inferior to the inguinal ligament. However, this results in a high femoral placement, and it is a difficult contour for the nurse to take care of when it comes to placing the central line dressing. So what we're going to recommend is called a mid-thigh femoral. So come down the leg just a little bit more, and the lower you can come, the flatter, the easier it is to take care of with the dressing. So again, a red, yellow, green. Red is up in the groin. We have to deal with feces and urine and other devices up there. So if we come down into the yellow, it's much easier to take care of. And if we come into the green, it's a lot easier to take care of. Do remember, though, that the diameter, the lumen diameter of the vessel becomes smaller as you come down the leg. And so you should only use this for small bore catheters. Again, for triple and dual lumen catheters, this is a fine technique. For dialysis catheters, you would not come this far down the leg. You need a big bore for that. Now, when you're looking at your vein, you used ultrasound to show that you're in the vein with your needle. That is the best way to tell that you're in the vein and not in an artery. But what we want you also to do is take the syringe off the needle and see that it's non-pulsatile blood. You can also use a fluid column and a manometer to show that you're in a low pressure vessel and not in an artery. But color is never the best indicator, because it may be bright red blood in a vein from being superoxygenated on the vent or on supplemental oxygen, or the patient may be hypoxic and the artery is a darker color than you imagine. So don't use color. The other thing we recommend is if you're good at an angiocatheter technique, the angiocatheter is in the central line kit, and this is a great technique for inserting the catheter and then the wire through the catheter. If you're not as familiar with angiocatheters, it may be just as well to feed your wire through the needle. But if you're from a paramedic or a nurse background, using the angiocatheter is actually an acceptable way and may even be superior than just feeding the wire through the needle. Do remember that the wire should feed easily through the needle or the catheter. If you're running into resistance, look to see where your wire is running into resistance. Your wire only needs to go in between 10 and 20 centimeters. The needle you're going through with the wire is 10 centimeters long. So once the wire has exited the needle at about 10 centimeters where there's one mark on the wire, that means that your wire is appropriately placed into the vessel. You do not need to go more than 20 centimeters. If you're starting to feel resistance at 10 centimeters when the wire is exiting the needle, it's probably because your needle has gone through the back wall of the vein and the wire is trying to dissect subcutaneous tissue. It should not feel like you need to force the wire. Recheck where your needle tip is, pull it back into the vein, and then feed your wire. And you can do this under dynamic ultrasound guidance also. Now, again, one more time, the wire has marks on it. One mark at 10 centimeters, 2 marks at 20 centimeters, 3 marks at 30 centimeters. Your wire only needs to go in far enough to make a track for you to follow with your catheter and dilator. Therefore, your wire only has to go in between 10 and 20 centimeters. Any more than that will result in you having to pull the wire back out when you put the catheter in. And it may lead to you losing the wire in the patient. So always maintain your guide wire by either holding it before the catheter or as it's exiting the catheter. But your hand, once the wire is in the patient, should always be touching the wire. The other thing is we want to try and prevent as much infection as we can. So anytime we traumatize the skin, we are increasing our risk of infection. So the best practice is not to use the scalpel unless we absolutely have to. The other thing is that we have to stop bleeding. And if we use a skin nick, we may have excess bleeding that we have to wait for it to stop. So not using the skin nick is the best practice. Sometimes you will still need to do this, but just remember, if you don't need to, don't do it. The other thing is the dilator can cause a lot of trauma. The dilator is really just to dilate the sub-Q tissue and not the vein itself. Therefore, when we insert the dilator, if our vein is only 1 centimeter deep, as it is with the IJ, then our dilator only needs to go into the skin about 1 centimeter. It does not need to be hubbed. Don't cause any more trauma than you need to. Now, when we're placing our central line, we've got to insert it to the right depth. This can be a little bit complicated, and people's anatomies are different, but a good rule of thumb is odd numbers. So the right subclavian is closest to the heart. Again, we're using a shorter catheter, so it generally goes in about 15 centimeters. The right IJ, 17, left IJ, 19, and then the left subclavian, there's no 21 centimeters on the catheter, so it just stops at 21. But if you can remember 15, 17, 19, 20 is an easy way to start off of how deep your catheter needs to be in, and then you can readjust it to the patient based on the x-ray. What about the line lock? So in our kit, we had a line lock. This is blue hub here. The line lock is for securing excess catheter. So if you selected the right catheter at the beginning, you won't need to use the line lock. If you put in a 20 centimeter catheter in a place where you only need 15 centimeters of catheter, you've got to secure that extra 5 centimeters. You need to use a line lock. So a line lock is an unnecessary tool. You shouldn't really need it. And so when we place our central lines appropriately, as this one is, you don't have to use a line lock. And then end your procedure well. So go after you've got everything done. We're going to talk about dressings next. You want to make sure you get a chest x-ray, make sure that your catheter is in the right place, that it didn't go up the wrong vein, that it's situated appropriately. You want to make sure there's no complications like a pneumothorax. Then you want to write your note, noting any variances in your procedure, and also you want to make an order so you tell the nurses they can use it, and that starts the whole maintenance bundle for the central line.